Good morning, everyone. Thank you joining again. It is my privilege to host this month's session. We have a wonderful speaker today, Dr. Karl Anderson. I can't believe that we are hosting a gastroenterologist, and we will hear, learn, and get his insights. He's been a legacy in the field of porphyria, Dr. Karl Anderson. He did his medical school at Hopkins back in 1965 and followed with the residency and fellowship medicine and gastroenterology at Cornell. And he's been a big advocate of porphyria and a big advocate of porphyria patients, as well as the education of the porphyria. So he's a professor in the Department of Preventive Medicine and Community Health at the University of Texas Medical Branch. And so we will go ahead and get started. This is Dr. Anderson's disclosures. I will start with the first case. This is a 41-year-old male patient with a history of multiple sclerosis and acute intermittent porphyria, complicated by multiple hospital admissions for constitutional symptoms, mainly severe abdominal pain attacks, brought him to emergency room with several abdominal pain, dark urine, vomiting, confusion episodes. His blood pressure and heart rate noted to be on the higher side. His basic lab was unremarkable, with the imaging also did not reveal any abnormality. His mild CKD along with minimal LFT elevation was noted, and the hematology consulted for recommendations. So the first question we will be asking Dr. Anderson: how do you approach to suspected acute hepatic porphyria cases in the acute setting, and what does your workup typically entail?
Okay. Well, I can begin with a little bit of introduction. The acute porphyrias, which are regarded as hepatic porphyrias, there are four of them. And well, the three that we see most frequently, which is AIP, acute intermittent porphyria, hereditary copper porphyria, and variegate porphyria. And these are autosomal dominant disorders with low penetrance. And they cause a lot of different neurological symptoms. The last two can also cause blistering skin lesions. And symptoms are associated with high levels of ALA and PBG, which are porphyrin precursors that are excreted in the urine and are important for diagnosis. And their formulas are shown here. And you can see they're porphyrin precursors. One's an amino acid, one's a pyrrole. They're not porphyrins. And so these are the four AHPs, acute hepatic porphyrias. AIP is the most common, and ADP is the most rare. There really only been eight documented cases ever reported. And each is due to a deficiency of a different enzyme in the pathway to make heme. The first is autosomal recessive and extremely rare, and the other three are autosomal dominant. And blistering skin lesions occur most commonly in variegate porphyria. It's actually more common to get skin lesions than neurological symptoms. And they can occur in HCP, but they're quite rare. In fact, I've never seen a patient with skin lesions and HCP. So the neurological symptoms are poorly understood. They're associated with increases in ALA and PBG, and these precursors may be neurotoxic, but that really hasn't been proven. Porphyrins are also elevated, and in VP particularly, they may result in skin lesions, photosensitivity, but porphyrin elevations are much more nonspecific. The mechanism could involve heme deficiency, and particularly in the liver, there's a regulatory heme pool that controls the first enzyme in the pathway, ALA synthase 1, and there's dysregulation of that due to the partial enzyme deficiency. And there could be deficiencies of specific hemoproteins. So it's said that NO synthase, which is a hemoprotein, may be deficient in blood vessels, and that could result in vasospasm, and that might explain particularly some of the CNS symptoms and possibly even abdominal pain. So AIP is due to a partial deficiency of PVG deaminase, also known as hydroxymethylbilane synthase. It's only decreased by half, so it's not a severe deficiency, and these individuals have heterozygous mutations for this enzyme. And the penetrance is very low. The prevalence has been found in the population of these heterozygous mutations is actually quite high, one in about 2,000 people. So that would indicate that the penetrance is maybe as low as 1%. It's also possible we're not recognizing symptoms that these patients may have often enough. Symptoms develop after puberty, most commonly in women, and that's not fully understood. The symptoms are very nonspecific. They usually occur in acute attacks, but they may become chronic, and all the symptoms of AIP are neurological. And they can involve the autonomic nervous system, the peripheral nervous system, and the central nervous system with a variety of manifestations. And this shows the most common symptoms. Abdominal pain is the most common symptom, and then there are a variety of others, but abdominal pain should really be the focus for improving diagnosis, because in clinical medicine we see unexplained abdominal pain all the time. You can get in the central nervous system with severe attacks. You can get press syndrome, which is it may be due to vascular spasm, and you can get these densities that are seen on imaging that resolve with when the attack resolves. The urine may be may be normal because ALA and PBG are actually colorless. Their porphyrins are elevated, so that accounts for reddish urine, which these patients often complain of. And porphobilinogen can also degrade to porphobilin, which has a brownish appearance. So the urine can be reddish or brownish, and so people often complain of dark urine. Exacerbating factors are things that affect the heme biosynthetic pathway in the liver, especially drugs that induce cytochrome P450 enzymes, since that's what most of the heme made in the liver is used for, is for P450 enzymes. Progesterone is a strong inducer of ALAS1 and P450s, and high levels during the luteal phase of the menstrual cycle can cause cyclic attacks in women. Fasting and carbohydrate restriction also induce ALAS1. It's strongly suspected there are other modifying genes, but these remain to be identified. Patients often complain that stress or report that stress precipitates attacks, but we don't know exactly how that works. So when would you suspect AIP, AHP, based on symptoms? Well, I think abdominal pain is probably the most important one to address. There are other situations, particularly in Guillain-Barré syndrome. There have been a number of patients, increasing number of patients over the years that were misdiagnosed as having Guillain-Barré symptoms when they developed severe motor neuropathies. So I really think that all patients with Guillain-Barré syndrome should be screened for acute porphyria. It's readily diagnosed by biochemical testing and also by genetic testing, but genetic testing is not definitive because penetrance is very low. So you need biochemical testing to demonstrate that the disease is active. So biochemical testing is most informative when symptoms are present. So it's important to test when patients present to the emergency room, when they're admitted to the hospital with abdominal pain or neuropathy, and it's important to know what you're going to test for. It's also important. A lot of people emphasize that we need to think of porphyria more often, but I think there are certain clinical situations where we just test for it, even if we don't have a high index of suspicion. Because in clinical medicine, we test for diseases all the time, even if we don't have a high index of suspicion. And for some reason, this is not done with porphyrias, and that's why there's such a delay in diagnosis. So there are many biochemical tests that can be done. So it's important to, when you're screening or doing what we call first-line testing, that the right tests are chosen and you don't just order every test that's available. Screening should emphasize sensitivity, so you don't want to miss cases. And then if first-line testing is positive, then you need to do second-line testing to see if it really is porphyria, and if it is, what type it is. And we have a lack of harmonization in the U.S., and this is less true in Europe, where they are better organized, but every hospital sends their tests to different laboratories, usually some of the major 4 or so commercial laboratories, and each of them does things differently. And so harmonization is lacking, and that means that physicians are confused and poorly educated about what to do. So whenever, my feeling is whenever there are symptoms that suggest porphyria, you should test for it, and without any hesitation, like we do for other diseases. And the most important would be somebody who presents with severe unexplained abdominal pain, say in the emergency room, and often if the initial workup, I mean, we do amylase, lipase, abdominal CT on almost every patient with abdominal pain in the ER. Whatever that first workup is, and if it's negative, then the next step should include urine PBG, and we also suggest measuring porphyrins. And I don't think the index of suspicion has to be high. We should just have guidelines that where PBG is part of the workup for unexplained abdominal pain, just like amylase, lipase, and CT imaging is. It's important to remember that porphobilinogen is a parole and not a porphyrin. So if you order porphyrins, you might not get porphobilinogen, depending on the lab. PBG, it turns out, is specific for these 3 most common AHPs. And it's particularly sensitive for AIP because the deficient enzyme the substrate is actually porphobilinogen. It's less sensitive for HCP and VP, which are due to deficiencies of enzymes further down the pathway. And it's thought that some of these accumulated intermediates may inhibit PBGD and raise ALA and PBG, but it's measuring PBG is definitely less sensitive for HCP and VP than AIP, and it's not elevated at all in ADP. But total porphyrins are elevated in all of these porphyrias. So if you want to not miss any cases, I think you should measure PBG and total porphyrins. But porphyrins are nonspecific, so if you get an increase in urine porphyrins, you need further workup to see if it's really is porphyria and which type. Because porphyrins are elevated in liver disease, and because porphyrins are partially excreted by the liver, and also in bone marrow conditions where heme synthesis in the bone marrow is stimulated. So when you order urine tests, I would order porphobilinogen and total porphyrins. And many people order ALA also, but ALA is less important because if PBG is elevated, if ALA is elevated, you're going to have elevation in PBG and or porphyrins. And it's not doesn't mean anything to order a porphyrin screen or a porphyrin panel because the laboratory won't know what you want. So first line testing, we recommend doing PBG and total porphyrins. Second line testing can be more extensive, more expensive, but because you've got a positive result, you've got a positive screening test, so it's important to work it up further. And we can go through those for each of the porphyrias. Also, DNA testing is available, and that's part of second line testing rather than first line testing. So the other biochemical tests include measuring plasma porphyrins and fecal porphyrins. Fecal porphyrins are not significantly elevated in the first two, but they're markedly elevated in HCP and VP. And you can actually distinguish these two by the patterns of the elevated porphyrins. Also, there's an important test which not many laboratories offer. It turns out in variegate porphyria, there are porphyrins that are elevated, and they're also covalently bind to plasma porphyrins, and that changes their spectrum. So if you do a fluorescent scan, you get a distinctive peak at 626 nanometers, and that's really diagnostic for variegate porphyria. So that's an important second line test, which is not offered by all laboratories, unfortunately. Genetic testing is very valuable, but it doesn't replace biochemical testing by any means. But it can be done earlier in the diagnostic workup than it used to be. If you find a mutation, it may not explain the symptoms, because biochemical testing, if it's normal, that means the condition is latent, as it is in most people who inherit these mutations. You can also, sometimes genetic testing identifies a variant of unknown significance, and we don't know, so we don't know if that's diagnostic or not, and so we certainly need biochemical testing to see if there is active porphyria present.
Yeah, I think we will continue with the same case as you mentioned about. So this patient's urine porphyrin was collected, and it happened to be elevated with the other intermediate metabolites, uroporphyrin, corpoporphyrin, pentacorpoporphyrin. They were all elevated. So the following question is going to be, after you make the diagnosis or after you confirm the diagnosis, how would you approach to acute attacks of porphyria patient in the hospital setting?
Well, do you have the normal ranges for those results? Because those are not the units that I usually use. That's a problem is, I mean, you can convert these units, but you have to remember the conversion factor, which often I don't. So this was, the PBG was elevated?
Yeah, this patient's PBGs were elevated along with the others. Corpoporphyrin
Okay.
3,
The other comment I would make is it's important to normalize to creatinine. We recommend you doing a spot urine, but not expressing the results per liter because it depends on how concentrated the urine is. I mean, the patient may be dehydrated and it could be very concentrated, or the patient may be getting lots of IV fluids and have a very dilute urine. So it's important, and some laboratories don't offer that, or they don't offer it unless you ask for it. Like Mayo, for example, never normalizes to creatinine, and the only option is to order a creatinine on the same sample and then normalize that yourself. So if we assume this is elevated, then that is, and it's not a very concentrated urine, then the other thing is that many of the laboratories have switched from column chromatography to mass spectrometry in the last, well, that's been at least over the last 10 years or so. And they've lowered the upper limit of normal, some of the labs, tenfold. And so that really, you can have a result that they say is 5 times elevated, but that level by the previous method, which everybody went by, is would have been in the normal range. So I think I think it's also important to look at the absolute number and have in mind what you expect to be a significant elevation of PBG and also porphyrins, because the same applies to porphyrins in terms of the normal range. So I think we've really got some values that come back that you could say are elevations of uncertain significance. You could call them EUS. So the numbers, and particularly when they don't normalize creatinine, these numbers can be very hard to interpret. And I would say these porphyrin elevations are not, well, the copper porphyrin 3 elevation may be substantial, assuming it's not a very concentrated urine. But that's very nonspecific because and it's found in liver disease in particular and bone marrow conditions. So the patient, it looks like the patient has a positive screening test, so you would need to work it up further. And so the ones that would be most important would be measuring fecal porphyrins and plasma porphyrins particularly using that scan method that I mentioned. Because those would differentiate HCP and VP from AIP. And after that, I would do genetic testing, which you won't get the result very quickly, but it's important to confirm the mutation. Partly because that enables screening of asymptomatic family members. So I think the approach in the hospital setting, I mean, for inpatients in the ER would be the same approach, basically.
Okay. I was trying to get into the treatment options for hospitalized AIP
Right.
patient. Yeah, we can move with this if you want.
Okay. So the treatment involves, first of all, you want to remove any exacerbating factors if possible. And then we have specific treatments, and we have supportive and symptomatic treatment. And then we have some methods of prevention. So the treatment requires an accurate diagnosis. If you have a high PVG and you're confident of that, that can only be due to the three most common AHPs. So after you should get all the samples you need for definitive second line testing, and then you can start this specific therapy, particularly with heman or panhematin. Also, you should, even a patient with AIP may have other conditions, so that needs to be considered also. We've had patients with AIP and Crohn's disease and pancreatitis, so need to think about other conditions. So hospitalization is often necessary because of severe symptoms, and they require narcotic analgesics and antiemetics and fluid and electrolytes. And then we have specific treatments which repress hepatic ALAS1. The longest available is glucose loading, which does have some effect, but it's not as potent as heman. So we recommend starting with heman if that's available. And if it's not available in the hospital at the time, you can do glucose loading for a day or so until the heman arrives. And it's given as a single dose. Usually we give 4 milligrams per kilogram once daily. And often the patient will improve in about 4 days, but sometimes it takes longer. So we continue it daily until the attack resolves. The duration of action of heman is short, so that's why we give it once daily. Package insert says you can give it twice daily, but that's really not necessary. It's rapidly degraded by hemoxygenase. So panhematin is what we have in the U.S. Hemarginate is available in Europe and some other countries. Is actually better because it's stabilized with arginine. It turns out now both are actually produced by the same drug company, but they're still marketing these two products in different countries for regulatory reasons, because it's hard to get a new formulation approved in any country. When they're infused, both bind to albumin and essentially become hemalbumin. So actually, we recommend stabilizing the panhematin with albumin before it is injected, and that prevents a lot of side effects. So we recommend that, but that's not in the package insert, so it's an off-label recommendation. So panhematin is actually a lyophilized heme hydroxide. It's pretty unstable. So as soon as you add water to it, it begins to degrade. And so we're recommending adding 20% albumin instead of water. So it has been used for prophylaxis, but you have to give it once or twice a week, which is usually not very practical. It often causes, when it's reconstituted with water, it causes infusion site phlebitis. And it also binds to platelets and multiple coagulation factors, so it actually prolongs the pro-time and PTT, usually for a limited amount of time. So bleeding is uncommon, but it has been reported. So we reconstitute it with albumin. Now, hemarginate is stabilized. It's actually available in liquid form to begin with, but it's not available in this country. So when you give heman, you get a rapid drop. If you measure PBG in the serum, you get a rapid drop over a few days. So you can get rapid improvement. If treatment is started early, the attack may resolve in a few days, but sometimes it takes much longer for treatment. So it's recommended that treatment should be started as soon as possible. Use glucose only for mild attacks or if hemon's not immediately available. It's not approved in pregnancy, but it's been used in pregnancy a lot and found to be safe and should be reconstituted with albumin. And we already talked about glucose loading. And the evidence for both of these treatments is not very strong because heman was approved more than 30 years ago and randomized clinical trials were not done. So liver transplantation is actually curative for the AHPs. And it was found in a few cases where they used the AIP liver to as a donor for patients with hepatocellular carcinoma, that this would transmit the disease to the recipient. So, which proves that the liver is the problem in AIP, even though the symptoms are all neurological. So it's kind of similar to Wilson's disease, where there is neurological problems, but disease is in the liver. The cause is in the liver. So gavosiran is an interfering RNA compound that's been available now for several years, and it's kind of a major advance. And it was approved by the FDA after high-quality clinical double-blind placebo-controlled trials. And it has many attractive features. It's long-acting. It can be given sub-Q and not intravenously. And it has few adverse effects because it's actually targeted for uptake in hepatocytes. But it does have some adverse effects. So it clearly goes to other places.
Okay, great. So I think you mentioned about the side effects of penhamin infusion.
Right.
Anything else you want to add?
No, I think it can also, if it's given repeatedly, it can cause iron overload, but actually iron overload is very difficult to diagnose in these patients because when you give heman, you get an acute phase response, and the ferritin goes up as part of an acute phase response. So if you have a patient that's getting weekly panhematin and you get the ferritin before each dose, a very elevated level may indicate an acute phase response, which can last, from our experience, that may last several weeks. And it may indicate an acute phase response rather than iron overload. So iron overload is actually probably an exaggerated problem with panhematin.
Okay. And you mentioned about the reconstitute with the albumin and
Right.
superficial thrombophlebitis. For thrombophlebitis, do you usually use mid-size IV accesses, or do you have any preferred way of infusing?
Well, it's best to use a central line, and many patients who have a lot of attacks or are getting prophylaxis have a port. You can use peripheral veins, but it's important to use a large one if possible. If you use a small peripheral vein and reconstitute with water, you're almost certain to get phlebitis at this infusion site.
Okay.
So that's certainly a limitation of panhematin. And so the pharmacy has to be instructed on how to reconstitute with albumin And that's actually become more difficult because there are very few guidelines for it. There's only one paper describing it, really. And it's more expensive and more uh, difficult for the pharmacy than reconstituting with sterile water. But
Okay.
most of the expert centers do reconstitute with albumin. If you reconstitute with the water, well, as soon as you add water, it starts to degrade. That's been shown. But if it's done down in the pharmacy with sterile water and taken up to the floor, that can be half an hour, and you'll get more degradation. So if it's going to be done with sterile water, the few centers that still do that, and there are a few, they do it at the bedside. So it has to be done by the nurses rather than the pharmacy. And usually the problem with that is usually a nurse who's on at a certain time has never done it before. And so that can, you've got an inexperienced person to administrate the drug. So we prefer to do it down at the pharmacy with albumin, and then it needs to be delivered to the floor as soon as possible because we don't really know how long it's stable with albumin. It should be started as soon as possible. In other words, before the reconstitution starts in the pharmacy, it should be determined that the IV access is available already, so that when it comes up to the floor, the patient already has an IV ready to give the panhematin.
Okay, so I will move this, and then let's say this patient started, excuse me. So this patient started the hemin infusion. And so the question is, how do you assess the treatment response in acute attack setting? Are you looking at the resolving abdominal pain or any other biochemical testings to confirm, or not, just to reassure the patient is getting better?
Well, we usually continue the treatment as long as is necessary to resolve the attack. So we're mainly following symptoms. When you give panhematin, like I showed in that slide, you get a rapid decrease in PBG and ALA, and that's a biochemical response. But neurological recovery can take longer. I mean, the abdominal pain may take longer to resolve, particularly if the attack is not treated promptly. And if you have a patient with severe motor neuropathy and paralyzed, it's going to take even longer. So we usually can continue the panhematin until at least the abdominal pain and other GI symptoms are resolved and the patient feels well enough to go home within a day or so.
Okay.
In patients with severe paresis, we have to individualize, and those cases are more difficult. Sometimes we follow the ALA and PBG and give it maybe every other day or twice a week during neurological recovery.
Okay, got it. So this patient started the hemin, 4 days went by, and then the hospital admission kind of complicated on day 7. The patient started to have respiratory distress and quickly become hypoxic and intubated. So how do you manage this neurological / respiratory complications that may be related to porphyria?
So he developed respiratory distress during hospitalization?
Yeah, so I'm assuming this patient was tested and excluded all the possible other etiologies and believed to be a porphyria related.
Well, usually if the patient started on treatment, they're not very likely to progress during treatment. Um, but their rate of recovery may be is quite variable.
And yeah,
But one reason to start on treatment as soon as possible after the diagnosis of acute attack is made is to prevent progression. Because
mm,
often severe neurological problems are later, and particularly motor neuropathy occurs um, after the patient's been having GI symptoms for at least several days.
okay, got it. So is there any occasions that you will be concerned for hallucinations, despite that you treat the patient with the 4 or 5 days of Hammond, but later the patient will become seizures, hallucinating? Is that also considered a neurological manifestation?
Well, it could be, particularly if you do imaging and you can see those densities on CT or MRI. Um, and these patients have to be treated for symptoms. Um, the seizures may be due to hyponatremia because they can get SIADH. Um, so the electrolytes need to be followed closely. Uh, if they have seizures, they need to be treated with anticonvulsants and anticonvulsants that don't make porphyria worse, of which there are a few. And so whatever symptoms develop, including psychiatric symptoms and hallucinations and agitation, those all need to be treated symptomatically, in addition to giving specific treatment with heman.
Okay, got it. And then maybe we should talk about a couple minutes about Givlari. And when do you
Yeah.
consider starting the Givlari medication?
Well, in the clinical trials, which are very well done, it was clearly shown that you get a rapid decrease in ALA and PBG. Um, and all the clinical trials were done on prevention of attacks, rather than treatment. So we don't know if givosiran is effective for treating attacks. It might be because the decrease you see is pretty rapid, but there haven't been clinical studies done looking at the response in a patient that comes in with an attack. So we still use heman for that. And we use givosiran in patients that have frequent attacks that recur after diagnosis. And the usual, well, there's no set criterion, but it's usually patients that continue to have 3 or 4 attacks, at least 3 or 4 attacks per year. We don't wait a year to determine how many attacks per year they have. If they if they have an attack every month for 2 or 3 months, that's certainly sufficient to start givosiran. And
Okay.
they need to be followed. Um, we prefer to follow them to use our infusion center, even though it's sub-Q, so we can get labs every week or every month and document decreases in PVG. Um, and again, these urine tests are now important for monitoring during treatment. So you need to have them normalize the creatinine because, patient drinks more water when they come in that day. Their PVG is going to be lower if you do it per liter. So when you're monitoring treatment, you have to have good measurements. And so these, they don't have the units on this slide, I don't think, but it was normalized to creatinine. And we measure ALA and PBG on these patients every month, and in our lab, and If it's per liter, they're all over the place, but if they're normalized to creatinine, they're nice and level. And again, this question about the normal range becomes important because um, you may send it to a lab that does mass spec, and they say on gavosaran it's still 5 times normal. Well, you've got to look at the absolute value and see if you think that absolute value is really significant, because you can see before treatment what the level of the ALA in the urine was in this patient or in this group of patients. They're very high. And you can see, I think the dotted line there is the normal range, um, and the company did their own measurements with this, and they did them by column. So if they're still, pretty close to the normal range and even a little bit elevated after normalization to creatinine, that's pretty good.
Okay. So
The
you
other
mentioned,
problem we have is the attacks decrease markedly in frequency, but patients still get attacks. And when we measure their PBG during those attacks, they're still normal. So this kind of raises the question about, well, for one thing, was that maybe it wasn't an attack, maybe it was something else causing the symptoms. And it also raises the question, do we really know that with every attack of acute porphyria, you've got to have marked elevation of PBG? Everybody says that, but if you try to find data about it, you really can't find data.
you also mentioned about at least a monthly.
Yeah.
Do you ever change the interval of each month, or do you do 4 weeks? I'm sorry, 5 weeks, sometimes 3 weeks for other patients. Do you space out or intensify more?
We usually do it every month.
Mm-hmm.
Um, Nobody knows how long it needs to be continued. Probably they don't need to be on this the rest of their lives. In the past, we did some studies with GnRH analogs in women with cyclic attacks, which in highly selected women that always had attacks during the luteal phase of the cycle, that was very effective. But we found that after a few years, you could discontinue it, and they didn't get symptoms anymore because that particular attack pattern wasn't permanent. So it's probably the same with gavosaran, that you have to consider how long you're going to continue it, because it's very expensive. And so at present, we we haven't been treating patients for very long. We have one patient who's now stopped treatment after 2 or 3 years, I can't remember. And she doesn't think she needs it anymore. And in fact, she's been doing very well off gavosaran. We have a couple patients who seem to need it less often than every month. Treatment often gets interrupted, particularly by insurance problems, because so often we have trouble keeping people on treatment because of insurance companies. And so sometimes if they go 2 or 3 months off treatment and they're okay, and well, usually we'll put them back on it every month and just remember that maybe after a year or so we might try it less frequently.
Yeah, that's very interesting, because technically, hypothetically, you would guess urine PBG is gonna be elevated again, right? But maybe it's not gonna be transforming to the symptoms.
Yeah.
Very interesting.
Well, that's right, because there are patients that have very high ALA and PBG that have never had attacks. most patients that are latent have normal ALA and PBG, but there are some that are called asymptomatic high excretors that have very high levels and haven't had any attacks. Those patients are probably more susceptible. And I've seen some of those who went on in the future, not too far long after, started getting attacks.
Okay.
But high ALA and PBG doesn't mean they have symptoms at the time.
Okay. So you mentioned about there was some concern with the homocysteine level among the Givlari treated patients. And so what is your experience? What side effects or long-term potential toxicities are you concerned of Givlari, especially the liver disease component?
Well, some of the patients with AIP could develop abnormal liver function tests, and we don't understand that exactly, but they seldom have cirrhosis. But some of them seem to have chronic, maybe 20% of them have some transaminase elevations chronically. And in the clinical trials, the patients who were treated with givosiran developed more abnormalities than the patients on placebo. So that's considered also a potential complication of givosiran. So we follow that. But usually, sometimes with continued treatment, it normalizes. So it hasn't been a big problem. The same with renal function. Some patients get chronic renal disease, and that may be due to ALA. And there have been patients that get chronic renal disease and go on dialysis and require renal transplantation, where the only cause was AIP. So it's clear that AIP can cause chronic renal disease that's sometimes severe. And also in the clinical trials, rising creatinine was more common with givosiran than with placebo. So we watched that also. But again, it usually doesn't progress, at least over periods of a year or two that we've been treating patients. And so I don't think it's a big problem, but it needs to be monitored. So I don't think we've stopped treatment. There were some patients on the trials who stopped treatment because of that, but very few.
How about the homocysteine part?
Well, the homocysteine part seems to be that givosiran it decreases the synthesis of ALAS1, which is the rate-limiting enzyme for heme synthesis in the liver. So it was actually found that it does decrease some P450s in the liver. And the effect on homocysteine is due to the deficiency of a hemoprotein enzyme that's in that pathway. So there does seem to be evidence of heme deficiency, at least in the liver, as a result of givosiran treatment. But homocysteine elevation, well, we usually give patients pyridoxine and B12 and folate.
Okay.
And that may decrease it. And nobody knows what homocysteine elevation is not very concerning because nobody knows what it does.
Okay. Yeah. So maybe this question is a little bit interesting because sometimes we refer for this our patient, he was tested and he was found to be a heterozygous pathogenic HMBS gene. And so again, as you mentioned, the penetrance is very low. Do you have any insight why is this so? I mean, we do see the gene mutation, but there is no urine or there is no symptoms whatsoever.
And you mean in relatives?
Yeah, in the relatives, yeah, in the
Yeah.
patient's relative.
Well, nobody knows. They're likely to be, well, we know that there's certain modifying factors. Women are more likely to develop symptoms than men, but hormones don't seem to be the full explanation because there's some women with normal hormone levels who never develop symptoms or elevated ALA and PBG.
Okay.
So they're probably modifying genes, and people are looking for those, but we don't know what they are yet.
Okay. So I think I want to stop here and ask if anyone has any question.
Hey, Dr. Anderson, this is Matt Hancock. Heman seems to potentiate the action of blood thinners. So I've always wondered why. I don't know if you have any thoughts, because I've seen horrible bleeding with patients on full dose anticoagulation getting Heman.
Uh-huh.
Any
Well,
thoughts on?
it was well the degradation products bind to platelets, endothelial cells, and coagulation factors in the circulation. And so they affect multiple aspects of coagulation. Um, and they have and even though, because of, I guess the effects on endothelial cells, they have a thrombotic effect on veins. Um, there was a guy who used to work with in Rockefeller in New York who he actually thought maybe some kind of new anticoagulant could be developed. So he uh, even published a paper on human-derived anticoagulant. Um, but fortunately, the effect is pretty short. These degradation products don't last very long. So there haven't been many patients reported to have bleeding after heman. But it's something to keep in mind. And well, I think it's good to use albumin. The problem is it's very cumbersome, and it's become very inconvenient to um, reconstitute with albumin, partly because the company a few years ago decided to put more heman in the bottle. It didn't increase the size of the bottle, which makes it more difficult for the pharmacy to follow the same directions. So anyway, the pharmacy has to work out that how they're going to do it. And also for some time there's been a shortage of it's reconstituted in glass bottles because nobody's determined whether it's safe to do it in plastic bags. And there's been a shortage of sterilized glass bottles. So I think last I heard, our pharmacy was having to use 1 liter glass bottles because there's a shortage of smaller ones. Um, so they were complaining, it's becoming more difficult.
Yeah.
But there are certainly advantages to doing with albumin, so we still ask them to do that.
And when you do in the albumin, do you still use the glass or do you use the albumin bag to reconstitute?
Well, the pharmacy reconstitutes it in glass
Still.
because nobody's. I mean, if you do it differently, you need to do some studies and see if if that affects stability.
Yeah.
We don't know if the human will bind to plastic or not.
And this is across the globe, right? The Europe is also doing the same in the glass.
Yeah, yeah. I mean, it's all off label. I mean, if you read the label, you're supposed to take the panhematin, which comes in lyophilized in a glass bottle, and you're supposed to add, I think, 40 cc's of water and infuse it. But we know there's immediate degradation and you get coagulation problems and phlebitis. So,
Interesting. No, it
and if
makes
you use albumin instead, it prevents all that. And hemarginate is stabilized with arginine, which is an amino acid that's found in proteins, including albumin. So that's a much better product, but it's not available in the US.
okay, great. I think to anyone, does anyone has any other questions? I think to respect everyone's time. Thank you, Dr. Anderson. I mean, I
Okay.
learned quite a bit, and that's my to-do list. I'm gonna talk with our pharmacy people and see what we are doing in our center. So that's
Okay.
awesome. So I hope everyone enjoyed.
Okay, thanks.
Thank you, Dr. Anderson, again.